We'll start again with anatomy. We saw this anatomical relationship when we talked about the pancreas, so I'm just going to go over it one more time. So here on the top right there, you can see we have our right and left hepatic ducts. What those do is they drain bile that gets created by the liver. Both of those ducts drain into the common hepatic duct. Over here, we have the cystic duct, which is important because that's our outflow tract from the gallbladder. And the common hepatic duct and the cystic duct both combine into this common bile duct here. That common bile duct will attach to the main pancreatic duct located throughout the pancreas. This is our primary pancreatic drainage system. And as we just said, it connects with the common bile duct. So in this region, you can not only have bile, you can not only have pancreatic enzymes, but you can have bile flowing through the distal part of this tract in this region. Something I want to note right here, I added it to the screen. You also have an accessory pancreatic duct, which has no connection with your CBD, but this can still drain pancreatic enzymes through this minor duodenal papilla. At the end of the main pancreatic duct, you have your ampulla of Vater, which is a widening of the duct right here. And this helps to increase outflow of both pancreatic fluid and the fluid coming from the common bile duct, like bile. Here we have our major duodenal papilla, which is the region of the duodenum that drains the main pancreatic duct. And you have to remember that there's something called the sphincter of Oddi or Oddi, which is a muscular layer surrounding that major duodenal papilla. And this can regulate outflow depending on whether it's constricted or relaxed. And the relevance that sometimes is tested, it's a little bit low yield at this point, but there's uh, some thought that morphine can cause this sphincter to spasm. And so if you have somebody with acute pancreatitis, sometimes morphine specifically is avoided. It kind of depends. I've seen different institutions say different things about this, but I just wanted to throw it out there for you. That's it for anatomy. The gallbladder anatomy is very straightforward. Let's talk about physiology. And when we're talking physiology, I really want to go in depth about bile and all of its components. So we'll talk about bile function, composition, bile secretion, reabsorption, and finally we'll talk about what happens when you have biliary obstruction and all the symptoms associated with that. So starting with function, there's four main functions you should know with bile. The first function I want you to recognize is that it helps to emulsify fats, so it helps digest fats and fat-soluble vitamins. We talked about this in the small intestine lecture, but I'll review it now. Just remember that lipids are amphipathic, and what that means is that they have a hydrophilic region, which likes water, and a hydrophobic region, which does not like water. So if this is a triglyceride here, a breakdown product of fat, you can see that on the end here, we have a hydrophilic end, and here we have a hydrophobic end. And the clinical significance of this is that if you have a fat globule in your digestive tract, what's going to happen is that the hydrophilic ends will all arrange around touching the lumen, and the hydrophobic ends will bundle together in the middle. The problem with this is that if you have pancreatic enzymes, when they try to get in and digest all of this fat, they're not going to be able to access this hydrophobic region in the middle as well, because they'll have to break through all this other stuff first. So their surface area is compromised a little bit. The good news is, though, is that bile is also amphipathic. So what bile can do is it can start binding in there and kind of break down this huge globule into a lot more small globules. And so you'll have pancreatic enzymes that can reach more surface area and break down these fats a lot easier through that process of emulsification. The second thing I want you to recognize is that bile is helpful for excreting waste products like bilirubin and cholesterol. And so if this is a bile that's in the gallbladder, it can get drained out. Once the gallbladder contracts, it gets drained into the duodenum, and then that can go out and be excreted in the stool. And what we'll find later when we talk about gallstones, we'll find that the two subtypes of gallstone are bilirubin gallstones and cholesterol gallstones, and that's because those are both being excreted and in some form within the bile. I also want you to recognize that bile can provide some alkaline fluid to counteract the stomach acid. We already saw in the pancreas lecture that the bicarbonate produced by our ductal cells in our pancreas is really helpful to neutralize that acid, but bile also plays a role in that. So if we have a bunch of hydrogen ions that made it into the duodenum, they can cause some damage, but fortunately, if you have bile there, it'll neutralize that as well to some extent. And bile also has some bactericidal activity. So when we eat food, oftentimes there's a lot of bacteria in it, and most of that bacteria gets killed within our stomach acid, but for the bacteria that makes it through the stomach, so if this is our food bolus, you can have some bacteria. Again, if it counteracts with bile there, then bile can also take out some of those bacteria to protect us. So what's bile made of? It's important to recognize that bile is made of a few things, mostly water. It's about 95% water. And then you're going to find bile salts. So the water, the electrolytes, and the bile salts will help keep it more diluted and less concentrated. And that'll be important to prevent things like gallstones forming. But you can also have cholesterol and bilirubin within this, as we've discussed. And there's many other components they're in bile, less, more low yield for step, but I just want you to recognize that bile is a cluster of several important compounds, most notably the water, bile salts, cholesterol, and bilirubin. So I'll draw that in a picture. So if this is our bile, just want you to realize that it's 95% water, and it's also made of these salts, cholesterol, bilirubin, and other products. And we'll go over this framework when we talk about gallstones. So how is bile secreted? Bile is synthesized in the liver, and after it's synthesized, most of it is sent directly to the gallbladder. And then once the gallbladder is activated by things like cholecystokinin, it's going to be secreted because the gallbladder will contract. So that looks like this. The liver will create the bile, and that bile will get sent to the gallbladder. And then once the gallbladder is activated by CCK, it'll contract. And then once it contracts, that bile can flow all the way down through your cystic duct, common bile duct, main pancreatic duct, the ampulla of Vater, out the major duodenal papilla, and into the duodenum. So we've talked about how bile gets into the duodenum, but how do we get some of it back? We don't want to waste all the bile. Most of it's actually reabsorbed in the intestines once it's done its job of emulsifying the fats. So the one thing it's important to recognize is that even though both bile and fat are reabsorbed, they're not absorbed at the same segment of our GI tract. So instead of being reabsorbed with the fat micelles, the bile salts get reabsorbed later on in the terminal ileum. And because of this location that it really prefers getting reabsorbed in the terminal ileum, if you have any damage to the terminal ileum, you can ultimately start having a bile salt deficiency and subsequent fat malabsorption. So I'll draw this here. If this is our lumen of our GI tract, we have our bile surrounding fat droplets, and pancreatic proteases and lipases are doing their work. In this case, lipases would be breaking this down. They can break it down into micelles, and those can flow into enterocytes. Now, bile that was just helping with that process cannot get into that same enterocyte. And instead, the bile will travel down the GI tract and before reaching the terminal ileum, and there it can be reabsorbed. But remember, if there's any damage to this terminal ileum, then you won't get any of this reabsorbed bile. So you'll lose it in the feces and the stool, and so ultimately you'll end up having less bile. And so this can cause fat malabsorption. Another thing to note when we're thinking about different cholesterol medications, there's a few things called bile acid resins, like cholestyramine, cholecystolam, and cholestyramine, and these intentionally inhibit this bile acid reabsorption by binding to the bile and not letting it escape in the terminal ileum. And so these medications will reduce your bile in your body, which reduces your fat absorption, and then so you'll likely have fatty diarrhea, but you'll lose some cholesterol in the process because you're not going to be reabsorbing all this fat. So it can have a clinical, there's a clinical utility to preventing this process as well. So now let's discuss biliary obstruction and all the symptoms associated when your bile ducts are clogged in any way. So we talked about bile being in our gallbladder and it flows out into the duodenum. What happens if it's blocked? It doesn't matter if it's blocked here or here or here, anywhere in the common bile duct or further, you're going to run into some problems. So when you have an obstruction, the bile is not going to be able to escape and it's going to leak out into our bloodstream. And what I want to do is I want to go over all the different symptoms that arise and laboratory findings as well that can arise based on biliary obstruction. I'm also going to put in the 5 components of bile, and when we talk about a symptom, I'll highlight which component of bile is predominantly causing that specific symptom. So let's kind of go over it, and I think it'll make sense. So for pruritus, if you've ever heard of somebody who has really bad liver disease or gallbladder disease like PBC, which we'll talk about later, you can get pruritus, and that's caused because as inside this bile are bile salts, and when you have a ton of bile salts in your blood, that can really cause a bad form of itching. For jaundice, so jaundice is caused by any sort of bilirubin in the bloodstream, whether it's conjugated bilirubin or unconjugated bilirubin. Dark urine is also caused by bilirubin in the bloodstream, but it's just the conjugated form of bilirubin that's causing the dark urine. And so I'm gonna show this in a graphic to make sure it makes sense to you. So normally, where are we getting our bilirubin anyways? Where's all this bilirubin being formed that we have to excrete through our bile ducts? What happens is that our red blood cells have a finite life. They only live about 3 months, right? And so when our RBCs finally die, they're going to release some bilirubin, and that bilirubin will be unconjugated bilirubin. And an important thing to recognize is that unconjugated bilirubin is insoluble in water. So it's water insoluble. So if this unconjugated bilirubin tried to go to the kidneys to get excreted, the kidneys basically throw it back in the bloodstream and say, I can't do that, because they're only going to help out with some some water soluble compounds. So now we have this unconjugated bilirubin that can't escape. It's stuck in our bloodstream. So how do we get it out? Well, the good news is our liver has some enzymes that can conjugate this bilirubin. So that will get sent here, and you'll have our UDP gluconeotransferase that we'll talk about in the liver section quite a bit that conjugates this bilirubin. And then that conjugated bilirubin is a component of our bile, as we've discussed, and this can get secreted into our GI tract. And so that conjugated bilirubin is now in our gut. And ultimately, that's how you get rid of it. But if we have an obstruction, like we just talked about, what's going to happen is all that conjugated bilirubin now can get into our bloodstream. And this conjugated bilirubin is able to get filtered by the kidneys, and that'll result in dark urine. So pale colored stool is caused by bilirubin, or actually a lack of bilirubin within your GI tract. So what's happening here is that normally bilirubin that makes it to your GI tract helps provide a brown pigment in your stool. And when I talk about the last symptom here, this decreased urine urobilinogen, I'll talk about how urobilinogen can be converted, if it's in your GI tract, can be converted into stercobilin, and that kind of gives the brown pigment that you see in your stool. Now, again, if there's an obstruction, you're not going to have any bilirubin in your GI tract, and because of that, your bilirubin will stay pale. I mean, your stool will stay pale. Steatorrhea is important to recognize as well. We talked about this in the pancreas lecture. It's kind of the same idea, actually. Steatorrhea is basically fatty stools. So you'll get this diarrhea, this almost like this osmotic diarrhea because you have so much fats in your stool and your stools will float. So remember from our pancreas lecture that our pancreatic acinar cells will produce these pancreatic enzymes. They'll flow through the ducts and make it into the main pancreatic duct and into our digestive tract to help out with breakdown of proteins and fats. So here's a fat, it'll get broken down into the smaller globule and everybody's happy. Again, though, if there's a blockage at the main pancreatic duct, what can happen is that you lose all these enzymes in the lumen. These fat globules don't break down and they're going to get excreted in the stool, causing steatorrhea. Hepatosplenomegaly can be caused with an obstruction because if you block this region here, you'll get a backflow to both liver and gallbladder. So you can get hepatomegaly. Um, Splenomegaly you can get for a few different reasons. I'm going to show you the most common reason you get splenomegaly in liver problems. Most of the time, your portal system is draining up into the liver, but if you have any blockage or obstruction in that region in your liver, it can actually cause a backflow. And so that backflow can ultimately reach the spleen and kind of push and cause higher pressures in the spleen, and that can cause splenomegaly. This is just one of a few different ways you can have splenomegaly. I just wanted to point that out while we're here. And we talk about that more when we talk about portal hypertension and other liver defects. Increased cholesterol should also make sense. We've talked about how having this obstruction can increase your bilirubin because it's a component of bile. So because cholesterol is also a component of bile, it should come as no surprise that having more bile in your bloodstream means you have more cholesterol in your bloodstream as well. And just like we talked about, conjugated bilirubin is also going to be elevated. The same reason we talked about with the dark urine, we have our unconjugated bilirubin. It gets conjugated in the liver, and that's why you'll see more conjugated bilirubin now on laboratory evaluation if you have biliary obstruction, because it's already gone through that conjugation. This is a good time to just talk about when unconjugated bilirubin would be elevated, just so you have a sense of what conditions to look out for on a test if the indirect or unconjugated bilirubin is high versus the direct or conjugated bilirubin. So the first thing, the most likely way they're going to test unconjugated hyperbilirubinemia is through hemolysis. So if we have a bunch of red blood cells, we already talked about how when they break down naturally, they release some unconjugated bilirubin. So if you have a condition where you're hemolyzing, where you're destroying your red blood cells for whatever reason, you can imagine that you can get a huge influx of unconjugated bilirubin in your bloodstream. And that can actually overwhelm the capacity of your liver to conjugate all these. And so if you check your blood levels, you're going to find a ton of unconjugated bilirubin. Another thing to keep in mind is that liver pathologies could cause an unconjugated hyperbilirubinemia. Again, if you imagine these guys are always trying to get conjugated when they're floating in the bloodstream, but if your liver's not functioning that well, this whole process might be deficient and you might end up with more unconjugated bilirubin than you would like. Let's move on to some other lab values. So the classic, what they call cholestatic liver function tests or obstructive liver function tests that I talk about in the liver section is having elevated conjugated bilirubin and elevated alk phos. We already talked about the conjugated bilirubin. So now let's go with what's alkaline phosphatase. So alkaline phosphatase is an enzyme that has a lot of activity in our liver, bones, and kidneys. So you can see alkaline phosphatase here, and it can be part of the bile. So it kind of flows down the same way that everything else does. So if you have an obstruction, you're going to have a lot more alk phos in your bloodstream, and so you can measure that. Uh, with that said, alk phos is not exclusive to the liver. So if you ever have a bone or a kidney problem, you can also be leaking out alk phos. So if you have an elevated alk phos, it doesn't necessarily mean you automatically have biliary obstruction. You also have to consider other things like Paget's disease of the bone and things of that nature. Gamma glutamyl transferase, or GGT, on the other hand, is much more specific to the liver. So if you have GGT, if you have a biliary obstruction and GGT leaks out, you'll have elevated GGT. But on the contrary to alk phos, if you had a bone or a kidney issue, your GGT is still going to be normal. So it's a lot more specific to the liver pathology than alk phos is. Decreased urine urobilinogen. This is one of the more low yield points, but I think it's very easy to understand. So I'm just going to point it out for you. Uh, how I think of urobilinogen is urobilinogen to me is a measure of how much bilirubin is in your gut, in your GI tract. Okay. So we know that conjugated bilirubin can make it into our GI tract. And from there, this can be deconjugated by our intestinal bacteria into unconjugated bilirubin and subsequently deconjugated more to your urobilinogen. So the more conjugated bilirubin that you have in your GI tract is directly proportional to the amount of urobilinogen that you will have in your that will be formed in your body. This urobilinogen can do a few things. As we saw before, this can get transferred into stercobilin, which causes your brown stool color, and which is why up here when we talked about pale stool, I was alluding to the fact that bilirubin is responsible for this dark pigment, and it's through this process that bilirubin provides that dark pigment as stercobilin. Uh, Instead of being converted to stercobilin, it can also be reabsorbed and excreted in the urine, which would cause urine to have its yellow pigment color. And so we can measure this. And like I said, the amount of urobilinogen that's in our blood is directly proportional to the amount that of conjugated or unconjugated bilirubin that makes it into our GI tract. So why is this important? So this can be important because if you think about let's say somebody comes in with jaundice and you know they have a really high total bilirubin and you're trying to figure out, is this hemolysis? Is this obstruction? Sure, on a test, they'll give you the classic unconjugated bilirubin is probably hemolysis, conjugated is probably some obstructive pattern. But what you can do here is you can kind of use this to guide your judgment too, if they give you this on a test. If you have an obstruction here, what's going to happen is that you're going to lose all that conjugated bilirubin into nothing's going to make it into the GI tract. So you will have very low urine urobilinogen levels. But on the other hand, if you had something like hemolysis, where you have a ton of unconjugated bilirubin, a lot of that still will make it be converted to conjugated and ultimately flow down here into your GI tract. So you will get an increased urine urobilinogen level in things like hemolysis because there's nothing stopping all of that bilirubin from eventually making it into the GI tract. So it's just a differentiating factor. Like I said, it's a little bit lower yield than others, but I wanted to point that out. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.